Buongiorno. Good morning. I'm Jill Furillo. I'm the Executive Director of the New York State Nurses Association. And with our organization, we are 42,000 members strong. Our recent group that did join with the New York State Nurses Association is a group of over 2,000 nurses from the Albany Medical Center. So we welcome them. In New York, as he stated, we are fighting very hard in our state to achieve policy based upon research that would improve patient care in all of our facilities, whether it be in the hospitals or the nursing homes or in home care. No matter where we provide care, it is our mission to provide quality care for our patients. Advocacy plays a very important role in achieving the kind of policy that research has shown that will improve patient care. And so in New York, we are developing more and more advocates who can help to educate the public, but also build a movement in our state for better staffing, which in our view, the research shows does improve the quality of care for patients. What I'm going to be doing today, I'm going to be presenting to you some of the evidence-based practice and the research that shows that the need for safer staffing in our hospitals is the right policy. And that this is based upon the legislation that was developed in California back in 1999, and then the regulations that were developed as part of the bill or part of the legislation to achieve nurse-to-patient ratios in every unit of the hospital. I do want to stress that everything that was done in California was based upon the research that was done prior to the establishment of the ratios, and then, of course, the studies that came afterwards that validated the project. In my own personal situation, I was the Director of Government Relations for the California Nurses Association throughout the 1990s. We introduced legislation back in 1993 to try to achieve the ratios. What was driving that was the way that the healthcare was organized and the economy of healthcare, where we had the HMOs coming into California, and they were basically establishing a practice where the budget for nurse positions and ancillary positions was based upon what HMOs were requiring. And the HMOs, their purpose was not necessarily to improve the care for patients, but rather to have a different kind of reimbursement system, which was based upon a capitated system as opposed to the prior system. And so, in response to that, we began to see changes in the patient care models. We began to see that less and less registered nurses were being hired. They were proliferating we would say people who did not have the appropriate training or education in order to provide the kind of care that became more intense, because the patients who were being seen at that time, the HMOs, were more or less keeping people out of the hospitals, but so that the people that would actually come to be seen in the hospitals were people that had higher intensity of care, higher needs, greater needs. And so we began to see that we actually needed to have more registered nurses and not less. And so as a response to that, we began to see the quality of patient care began to go down. We also had the proliferation of for-profit hospitals that came into California. And their system was not based upon improvement for care, but it was simply based upon the drive for profits. And that did drive down the quality of care. And so what happened there was that we began to collect data in California. The registered nurses began to collect data. We did several kinds of studies of our own, and these studies were based upon the, we call them assignment despite objection forms that nurses were filing. You may be familiar with that. In the New York State system, we have what's called the POA, the protest of assignment forms. That would be where nurses would fill out these forms whenever they believed they were on a unit that did not have appropriate staffing, and as a result they felt that they needed to document some of these unsafe conditions. So in California, these were called the assignment despite objection forms, and nurses began to fill them out throughout the hospital, on the night shift, on the day shift, in the nursing homes, throughout the whole industry. And as a result, in collecting this data, we brought this data to the Institute of Medicine. And the Institute of Medicine, when we brought this data, we brought many nurses to the Institute of Medicine to testify about the conditions in the hospitals in California and how the quality of care was going down. And they were, basically laying nurses off and replacing nurses with unlicensed assisted personnel. And so when we went to the Institute of Medicine to discuss this practice, we brought the ADOs, assignment despite objection forms, and we were able to show them through this data that there were problems. What the Institute of Medicine said was that right now there is no evidence, there are no studies that are showing how this is either improving care, these systems, this system where you were replacing registered nurses, there isn't evidence as to whether or not this is harmful to patients or harmful to the patient outcome. And so they said, so there's nothing that we can do other than study the issue. And so what happened was the Institute of Medicine decided to study the issue. And they developed a project that went on for a few years, and they finally published the results of that study that was published in the year 2000. And that study was called To Err is Human. I don't know how many of you remember when that study was published, but it was published, I believe, in the year 2000. And it was actually announced in the Rose Garden at the White House that the Institute of Medicine has developed a study, and it focused on the medical errors that were happening in hospitals throughout the country. And what the study showed is that there was an increase in the number of medical errors that was happening throughout the hospitals. And that they said one of the factors about the medical errors had to do with how do you intercept these medical errors? What is our system for intercepting medical errors? And we know that the system, those of us who are registered nurses know what that system is, and it's us. That the presence of the registered nurse, because we're the patient advocates, our role is to ensure that the patient is being protected. And it's actually in our duty of licensure. And so what was happening in our hospitals is that if you have a decrease in the number of registered nurses and the nurses are being replaced with unlicensed assisted personnel, the chances are is that it's possible that there would be an increase in the medical error rate. And in fact, that was validated by the study To Err is Human. And so after the publication of that document, the To Err is Human, that is when the California Nurses Association was able to prove that we already knew, and we had been advocating for this legislation for many years. We were able to pass a bill in 1999 under the premise that we believed that this prevalence of medical errors was directly related to the fact that the registered nurses were being replaced, and as a result, that was validated in the year 2000. And so what happened was the Department of Health in the state of California recognized that study and began a process of promulgating regulations in the state to develop what the appropriate ratios would be in California. So that takes us to the Affordable Care Act, which would be the next slide. And waiting for all right, so then, the bill was passed in 1999, and then the regulatory process began in California based upon, again, To Err is Human. Since the passage of the Patient Protection and Affordable Care Act in 2014, hospitals have come under increasing scrutiny for the patient outcomes, including the readmissions to the hospital. Now, going back to the California experience, after the bill was passed and they were promulgating the regulations in California, We did additional studies to show what were the patient outcomes in California, what would be the appropriate number of registered nurses. And as a result of what happened in California, the Center for Medicare, which is the payer for hospitals and nursing homes, they're the ones that receive the payment for the provision of care. And the CMS actually did a review of the California law and the project after the regulations were passed, and actually gave this review gave it a positive review and a recommendation. So that now you have a government agency that is saying what happened in California was a positive experience. And so when the Affordable Care Act was passed, one of the recommendations about readmission rates came directly from the experience in California, because they saw that the readmission rates improved. So the next slide. And here we see that the Medicare readmission rates started to fall in 2012. This was after the passage of the Affordable Care Act. And this is because hospitals are now being reimbursed based upon their readmission rates. And the whole premise of readmission is that the patient should not have to be readmitted. And if they are being readmitted, maybe there was something wrong during the patient's first stay in the hospital. And so this is another research project that was done that shows that the readmission rates have begun to fall. Next slide. So the California staffing law drove the national policy goals in the Affordable Care Act. So what we saw was that, as I mentioned, AHRQ, they did their study on the California law. It increased nurse staffing levels. It created more reasonable workloads for nurses. It led to fewer patient deaths and led to higher levels of job satisfaction. And that's what the studies show, and that is what CMS saw as well. Next slide. And of course, we always knew from the 1990s, we knew that safe staffing was really the answer in California, and that if we could drive this policy, that the actual research or the evaluation of this policy would show that things would have improved in California, and that has been the case. Next slide. And here's one of the studies that shows that researchers have established that heavy patient workloads for nurses are directly associated with poor patient outcomes. I don't know if that's been your experience, but maybe you can tell me about that. Do you have that experience? You want to talk about that?
It's just from a private point of view.
Okay.
I'm pretty sure that exactly this was the killing my dad 1 year ago.
So there's an experience there. Okay. And of course, many studies have found that heavier nursing workloads were associated with more patient deaths, or that would be patient mortality, patient complications, and medical errors. And this one study by Linda Aiken, who is a noted academic, found that each additional patient added to a nurse's workload increased mortality within 30 days by 7%. So every additional patient you have beyond, in California, it was the ratio is 1 to 5 on the medical surgical units. There would be a 7% increase in patient mortality. Next slide. In the ICU, we look at how they impact certain unit types, and the difference between the units that are safely staffed and the unsafely staffed unit becomes even clearer. For ICU patients, an additional RN per patient day could lead to dramatic decreases in adverse patient events, including death, the patient mortality. Next slide. After surgery, more nurses, safer patients. After surgery, an additional RN per patient day can lead to dramatic decreases in the likelihood of surgical wound infection and other adverse events. This is what the studies have showed. Next one. Unsafe staffing and the nurse impact. So there's a 23% increase in the risk of nurse burnout. A 15% increase in a nurse being dissatisfied with their job leads to increased turnover and an unstable workforce. Have you seen that in your facilities? Have you experienced that? And we all know that the cost of nurse burnout or nurse turnover is high. Now, I believe in the US, it's up to about $75,000 every time you lose a nurse and you have to recruit a new one. So in California, the important victory that created the impetus to drive much of this study, the study results. And this fight involved a concerted grassroots campaign in coalition with other healthcare stakeholders. The fight was won because we had people who were organized and people who came together to, number one, collect the data that could then drive the research, that could drive the policy, and then to evaluate the policy. Does the policy work? And in fact, the answer was yes in California. What the California law requires, the ratios took effect in 2004. So in California, we were studying the issue. They promulgated regulations. The Department of Health Services decided to sponsor a study through the University of California, and they did a statewide study, and it took 2 years to do the study, but after that, they then came up with the recommended ratios, and those ratios were implemented in 2004. In the medical surgical units, they were mandated to have 1 nurse for every 5 patients. They began with a phase-in. In 2004, it was 1 to 6 in the medical surgical units, and then phasing in the 1 to 5. And the staffing levels shown in the grid were created by the Department of Health. So it was a result of the legislation having been passed that said that the state had to do ratios, and then after the ratios were, after the legislation was passed, then the Department of Health mandated these regulations. There was much input from labor, from the California Nurses Association, as well as from people, stakeholders in the industry, and academics. Next one. So what was the opposition in California? The opposition to doing this, these were the things that you're hearing now nationally. Loss of autonomy in the facility administration, that somehow if you have mandated minimum safe patient ratios, that you would lose autonomy in your practice. Financial hardship, that this would create problems for the hospitals, that they would lose money, hospitals would have to close. That ancillary and technical staff reduction would happen as well, because when you have to meet the nurse-to-patient ratios, you'll have to lay off ancillary staff. And that distressed hospitals will close faster. And the reality of that, and if you look at the California project, is none of those things happened in California. In California, the, next slide. In California, what we found is not one hospital closed as a result of the implementation of these ratios. And remember, that was in 2004. Not one hospital closed. Every hospital made so much money. They made more money within the time frame when the ratios were implemented than they had in the prior 10 years to the implementation of the ratios. And actually, what the law required, AB 394, was that the Department of Health would have to do a review of the ratios 5 years after they were implemented. And if there was such a problem, that they would then look at the law and say, did hospitals close? Did people lose autonomy in their practice? Was it a financial hardship for the state of California? And 5 years after this bill was passed, they did this review. It was a review that was required by the law. And what did the review show? That none of those things occurred. And so those ratios today are still in effect. There was no attempt by anyone to undo the ratios in California. No one in the hospital management, no one from the California Hospital Association, no hospital, no payers tried to undo those ratios. Why? Because all of the studies showed the benefits of such a policy. here we are. This is some of the data that proves what I just said. Hospital margins improved in California. Next slide. Ancillary and technical staff reductions did not occur. All the studies have shown, and these are studies done by academics throughout the country, that those levels did not go down, but the number of nurses did rise. Next slide. Okay, so that brings us to New York. After the California ratios were implemented, many different states have tried to do the same. Why have they tried to do the same? Because the CMS, which is our federal regulator and payer, said this is a good project. So why wouldn't we want to do such a thing? The research shows it. The policy should be driven by research and data. And we believe in that. And so in New York, the New York State Nurses Association had introduced similar legislation to California's legislation many years ago. And what happened in New York was that the hospital industry have spent much money along with other interested parties, such as the pharmaceutical companies, spending a lot of money to fight against the implementation of ratios. This has happened nationally as well. But what's interesting in New York is that New York actually has already legislated and mandated nurse-to-patient ratios, but not in every unit, only in certain units, such as in the liver transplant unit. There are some that are required in the emergency room. There are some that are required in the CCU. So we actually have already, in the policy of the state of New York, legislated and mandated nurse-to-patient ratios. The problem is that in New York, the acuity of the patients has risen. That we all know that through technology, that we have patients now that are in our hospitals that never used to survive, but now they are. And so this requires more intensive care. And these patients are no longer just in the ICUs and in the CCU and in the liver transplant units. These patients are now throughout the hospital. You can go to any medical surgical floor, you can go to a step-down unit, you can go to a tele-unit, and you will see ICU-type patients in these units. And you can tell me whether or not this is what you're seeing as well in your facilities. But I know that to be the fact in New York. So in New York, what we began to do in New York were to take the POAs that had already been part of the process within New York. People were collecting POAs, but they never had actually taken the data from the POAs and aggregated it together to present testimony to the legislature in New York and to present the data to the Department of Health in New York. And so we began this fight for safe staffing in a more intensive way in 2013, 2014, and began to collect that data. And where we're at in New York right now is that, okay, so the hospital safety crisis in New York. So what the POA data shows is that the situation in New York is really dismal. And we know that ourselves as nurses because we hear from the nurses. And the POA data shows it. What we've seen for the last 2 years is the Leapfrog Studies. Leapfrog is a national patient safety system that studies patient safety in all the hospitals throughout the country. And that what we've seen in the last 2 years is that New York has received the worst scores ever from the Leapfrog group. And when asked by the media, why is this so, they say, oh, we don't really believe in Leapfrog. But the truth of the matter is that Leapfrog was created by the hospitals to police itself. So how could you not believe in what your own data is showing? But the reality is that the patient safety mechanisms in place in New York are a problem, and our POA data has shown that. When we put together this data in New York, we have a bill, next slide. As you know, Roni, he's doing, besides doing the slides, he's taking pictures and everything else. Okay, so next slide, Roni. So walk away.
Should talk more.
Yeah. Okay, so here's the POA. We started documenting these unsafe practices through the POAs, and we collected thousands of them. And so we presented this documentation to the legislature in New York State. We finally had the data, the research necessary to be able to drive the policy in New York. And we presented it to the legislature, and in 2016, for the first time ever, after years of running this legislation in New York, the State Assembly in New York passed our staffing bill, which is based upon somewhat the California policy with some tweaks based upon our own realities in New York. And those realities I just stated, that the acuity is so high that these patients who were seen in ICU before are now being seen in medical surgical type units. Next slide. And so these are the numbers in the New York State bill, very similar to California. There's a couple of tweaks when it comes to the med-surg. What our proposal in our bill is in New York State is 1 to 4, because California's bill was passed many years ago. Acuity is higher here in New York. In California, many of the hospitals have 1 to 4 in their med-surg unit. Because remember, these are just the minimum requirements. You can also improve the staffing using your acuity system. And in California, the acuity systems are mandated so that you meet the minimum ratio. Then you have to have an acuity system in place where the needs of the patients are what is considered when you add more nurses or ancillary staff, whatever your needs might be. And that is a requirement in California. We believe that should be a requirement in New York once the minimum number has been met. And so what happened last year, because we've been collecting this data, the POA data, and because of the Leapfrog report that was dismal, truly, for New York. Again, worst scores ever. We were able to get some movement, not just in the California Assembly, the New York State, I'm getting my states mixed up. There's similarities in those two states, and that the kind of patients that we see in New York and in California are very similar. Very diverse population, and we have lots of folks who don't have access to care because of a lot of people don't have insurance, which is another problem we have in the U.S. In New York, besides having our bill had passed through the Assembly, the governor of the state of New York, Andrew Cuomo, issued a directive to the Department of Health to study the staffing levels in our facilities, in the healthcare facilities, not just the hospitals, but also the nursing homes. The reason for that is that the hospitals, every time we were running our legislation in New York, the hospitals will come to the legislature with all of the high-paid executives and all of their lobbyists and say, oh my God, in order for us to, if you were to pass this legislation, what would happen? There would be loss of autonomy of care. Remember I showed you what they said in California, loss of autonomy in care, that it will put the hospitals in financial distress, hospitals will close, and it's going to cost billions of dollars. This is what they say. In order to implement those minimum ratios, it would cost billions of dollars. We don't believe what they say, and so we believe that research should drive policy, and that if you study the staffing levels in New York, and then we come up with what those numbers might be, that is what should drive the policy, and not just what people say, but what the studies show. And so the governor of the state of New York now has in his budget this year a staffing study based upon improvements of care or enhancements to care. He wants to study what the costs will be to implement the bill that we have put into the legislature, to see actually how much that would cost, to see are the hospitals telling the truth, is it going to cost billions of dollars? We don't believe it will cost billions of dollars. These are minimum ratios. But also what the study language says in the report, in the budget language, is that there should be improvements to care. So we want to study that because we believe, in other words, we believe what the nurses are saying. And that's really important. If you have your policymakers who actually believe what you're saying and you have the studies to back it up, which we do have with our POAs, we believe we're on the right track. We're also running legislation this year that will help to drive the budget, and the budget will drive the legislation based upon what the needs are for New York State. The POAs that we've been collecting throughout the state this year have shown that instead of things improving this year, things have gotten worse. And I have two people that are here to talk specifically about the collection of the POAs in some of our major academic medical centers. These are major academic medical centers that spend millions of dollars on advertising. And you've probably seen some of the, if you're from New York, you've probably seen some of these advertisements. One of the hospital systems advertised on the Super Bowl, which, we know the cost of, buying an ad for the Super Bowl is quite expensive. Another one of these systems bought an ad recently for the Academy Awards on television. And another one made a full-scale movie about how great they are. So I'm going to bring up these two nurses who are members of the New York State Nurses Association, our Vice President, Anthony Ciampa from New York Presbyterian, Mary Fitzgerald from Montefiore in the Bronx, to talk about the collection of data and what the research shows.